So good afternoon. This is Marina Vivarelli from Rome, Italy, and it is my great pleasure to introduce this ERKNet and ESPN educational webinar on renovascular hypertension. Today we are very lucky to have a wonderful speaker, Professor Jelena Stojanovic. She is talking to us from London, UK. Jelena graduated from the University of Belgrade and is now a pediatric nephrologist at Great Ormond Street Hospital for Children in London. She is also a honorary consultant at King's College Hospital and a senior lecturer at UCL. Her main interests and expertise are in renal transplantation and renovascular hypertension. She is the lead for renovascular service at Great Ormond Street Hospital in London, and she co-leads the transplant service at the same hospital. She also leads PELMAT, which is a program in pediatric London transplant working group as part of both liver and kidney transplant service. And she is chief investigator for the unique study, Understanding Children with Multi-Organ Transplants Quality of Life, which is a UK national study. She has also been elected EKITA member at the European Society for Organ Transplantation and chair for audit and registry at the British Association for Pediatric Nephrology. And she is the lead for junior doctors in her department. So it is for us a great pleasure to introduce Professor Stojanovic, and I'm sure she will give a wonderful talk. I would remind you that you are muted during the entire talk, but at the end, we will take questions. So during the seminar, any questions you have, send them through the question box in the GoToWebinar window, and we will make sure that you get an answer at the end. So without further ado, let's hand it over to Jelena Stojanovic.
Thank you, Marina. Thank you very much for this very kind introduction. And thank you for the ERKNet and ESPN collaboration for the invitation to give this talk on renovascular hypertension. And at the start, I would of course like to thank Dr. Chaltulus, who has been an excellent mentor and has provided great amount of teaching support and opportunities to me throughout the years. So what we will talk about today in the next 30 to 35 minutes, we'll talk about the definition and etiology of renovascular hypertension. We'll spend some time looking into the manifestations and investigations, and I will share several cases with you. We'll look into the treatment and clinical outcomes, some of the innovation that we are using in the renovascular service in our hospital, and if we do have the time, we might hear a message from one of our renovascular patients. Can we please put the poll question 1, Stephanie?
Can you see it?
I can't, but I hope that the delegates can.
Yes, yes.
So 5 more seconds. I'm gonna close. Marina, will you read out the results?
Yes. Jelena, the question was, how many renovascular patients have you managed so far? And the results are that more than 5 was the most frequent answer with 59%, followed by 6 to 10 by 22% of the people who are connected today. 12% of the webinar audience follow more than 10, and 7% none.
Okay, thank you. Well, I hope that this will be useful because it seems to me that the delegates do have involvement with renovascular patients, which is excellent. So we'll start by defining the pathogenesis of the renovascular hypertension. So the definition for the renovascular hypertension, the simplest one, is that it is any flow-limiting narrowing in the renal artery system. And this can be isolated, or more frequently, it can be multifocal. So what problem can the flow-limiting narrowing in the renal artery system cause, and what happens? What is the pathogenesis of it? Well, it essentially leads to the upregulation of the renin, angiotensin, and aldosterone system, and that then leads to the hypertension. There is an initial stimulus, and we'll see later, which can be internal or external, which activates this system, which leads to the oxidative stress and some endothelial dysfunction, with formation of the neoantigens and some T cell activation as well. Along with that, the cytokine release and vasoconstriction with natriuresis follows, and we get sodium and water retention with increase in the blood pressure. What can cause the renovascular hypertension? Simply speaking, these causes can be internal or external. From the internal ones, the commonest reason is definitely in pediatrics fibromuscular dysplasia, or commonly known the FMD. This is associated with middle aortic syndrome. And we must not forget that post-kidney transplant, we can also see the stenosis, which can lead to the renovascular hypertension. Looking into the external causes briefly, any compression from the abdominal masses can cause it, or we often see distorted abdominal anatomy after the radiation therapy, which can cause renovascular hypertension. However, if we look into the more detailed classification of the causes for renovascular hypertension, then this table certainly gives more information associated with some of the common syndromes as well. So fibromuscular dysplasia and middle aortic syndrome are defined as non-inflammatory causes, while inflammatory causes include Takayasu arteritis, Kawasaki disease, and polyarteritis nodosa. There is an ongoing debate, is it an FMD or is it Takayasu arteritis? And sometimes the answer to this question will depend whether you're asking a nephrologist or a rheumatologist. A lot of syndromes are associated with renal artery stenosis, such as neurofibromatosis type 1, which is the commonest syndrome seen, Williams syndrome, and Alagille syndromes. Trauma and radiation can also cause the localized tissue damage, which can lead to the renovascular hypertension. And as I said, compression by masses, and by masses we mean Wilms tumor, neuroblastoma, or some other masses. Sometimes renovascular hypertension, rarely reported in the literature but seen in clinical practice, could be catheter-related, causing thromboembolic disease, or sometimes seen in hypercoagulable states such as the nephrotic syndrome, or it could be idiopathic. A couple of years ago, Dan Weering and colleagues have reported that on a cohort of 37 children, this is from our center, with renovascular hypertension, 14% had germline mutations, and about a third of them were found to have a variant of uncertain significance. So what does actually happen on the anatomical level? On the left side of this picture, we can see the normal arterial anatomy with the intima, media, and adventices as a fibrous outer layer. In fibromuscular dysplasia, the media is distorted and there is the fibroplasia with cells which are rigid and are not that elastic as the usual cells that we would see in the normal anatomy. And this means that the arterial wall is less responsive and adjustable to any of the stresses, so it is rigid. The high blood pressure can, with time, cause saccular aneurysms, which we often see in a long-term untreated patients. Arterial dissection is also commonly seen in this patient, and this can be either caused by the catheters during the angiographies and angioplasties, and we'll talk a little bit more about this when we move on to the treatment section. So these are very fragile vessels, and therefore any intervention, either endovascular or surgical or any other operations that these children might have, would be classified as a high-risk surgery. This is important to remember for any of these children undergoing any other interventions or any other operations, not only renovascular. So how common and how prevalent actually is the renovascular hypertension? Well, most definitely it is underreported. And the reason for this is that the blood pressure screening recommendations for children above the 3 years of age are not always followed, as we have seen in the numerous reports from various hypertension services around the globe. 36% of the children who were screened will have a hypertension. And this has come from a paper which was published about 6-7 years ago in Journal of Pediatrics. Renovascular hypertension, although only reported to be the cause for 5 to 10% of all of childhood hypertension, is still in the top 3 most common causes for secondary hypertension. The commonest one being obviously glomerular diseases. In our service at Great Ormond Street Hospital to date, we have 182 patients with renovascular hypertension, and our non-renovascular hypertension service has around 160 patients. A couple of years, a decade ago actually, reports on the 19 patients reported that nearly 40% of hypertensive patients had renovascular cause. So how can these patients actually present? If we look into the extensive literature, this can range anywhere from being asymptomatic in majority of the cases to actually presented with severe conditions such as heart failure. A good number of patients will present with cerebral symptoms and signs. Some will have hypertensive retinopathy. Encephalopathy is also something which is commonly seen, or even seizures. But I would like to stress out that these are the percentages which will not add up, because they are the highest reported clinical presentations for renovascular hypertension from all the papers in the literature that I get a hold of. So from being asymptomatic in a third of the patients to actually having heart failure. So very, very variable clinical presentation. So when we looked a couple of years ago in our clinical presentation, in our data at the GOS, at that time we had 165 patients, and this is a service that's been running for 22 years. 37% of the patients were asymptomatic, so this would go along the data which was reported in the literature. But what we have found is a significant number of our patients presented actually with heart failure, and actually more than what it is reported in the literature. And that can be explained by the fact that our center serves as a national and international referral center, so we do get patient transfer from other units. Interestingly, the variability of presentation with neurological symptoms and signs, which can include anything from retinopathy, encephalopathy, hemiplegia, or Bell's palsy, is something that we have also seen in high prevalence in our patients. So talking about these neurological presentations, it wasn't up until recently when the paper started to report the children with renovascular hypertension, and Dr. Ganesan and her team of neurologists and neuroradiologists have actually looked into the 34 children who were followed up and who have either moya-moya disease or occlusive cerebral vascular disease, so presented and followed up for complex cerebral arteriopathy, and they have retrospectively then been diagnosed with renovascular hypertension in half of these patients. Therefore, the advice from this paper was that children who present and who are followed up with complex cerebral arteriopathy should have the blood pressure checked, because majority of them might end up having renovascular hypertension, or therefore with it associated renal artery stenosis. We have written a systematic review. This was an invited review by Professor Flynn for pediatric nephrology, and looked into the clinical and radiological cerebrovascular abnormalities which are associated with renovascular hypertension. And in the literature today, there is 303 patients in whom there is a wide variety from 16 to 79% of those who had some cerebrovascular involvement. This would mean having the renovascular hypertension, renal artery stenosis, and abnormalities in the cerebral vascular bed. Those are usually the patients who will have a difficult to control the blood pressure, so maybe this is one of the indications for the patients to undergo full systemic evaluation. And what we mean by the cerebral arteriopathy, it can be anything from having the asymptomatic veno-occlusive disease to children who will present with stroke. So why should we measure the blood pressure in all patients and as per recommendations? So this was the first case that I will share with you. It's a 3-year-old girl who has presented with slurred speech, dribbling, and saying that her right arm was not working. So this is a 3-year-old noticing that her right arm was not working. She was taken to the local accident and emergency room, but these symptoms resolved by the time she was seen and she was sent back home. A couple of days later, she complained that she had a heavy and weak arm and was taken back again to the A&E, where she was found to have a systolic blood pressure of 220 millimeters of mercury, way above the 99 centile. Her brain MRI showed that she had carotid artery stenosis and unfortunately has suffered some cerebral ischemic lesions. Her ultrasound showed that the kidneys were both on the 50th centile, but she has had a bilateral parvus et arvus waveform, and we'll look into these images later on. Her DMSA showed the pretty much equal uptake in both of the kidneys, but this DMSA was done only after the second angioplasty because due to her presentation, she received urgent angioplasty on the day when she was admitted to a hospital. Her angiography confirmed severe middle aortic syndrome and bilateral renal artery stenosis with some SMA and celiac conclusion. She is currently under our follow-up for the last 3 years and undergoes 6 monthly angioplasties and currently has a blood pressure which is controlled on 3 antihypertensive medications. We are planning a definitive vascular surgery for her, but are allowing her to grow a little bit more. Now, I've said here that the SMA and celiac conclusion has been noted. We do not recommend any interventions on the occluded vessels, such as SMA and celiac, because for these inborn conditions, the IMA or the inferior mesenteric artery usually hypertrophies as part of the development and supplies the bowel provides the blood supply to the bowel. This is called the arc of Riolan, and you can read a little bit more where that comes from. It has associations with France. So the inferior mesenteric artery usually provides sufficient blood flow to the bowel. The reason why the advice is to really not touch SMA and celiac is that any possible associated complications such as infarction or thrombotic embolism can lead to the gut loss and subsequent death. It can be tricky to diagnose renovascular hypertension. So this was a story of a 9-month-old boy who was referred to us from overseas at the age of 9 months. He presented at 6 weeks of age to the local pediatrician with failure to thrive and was diagnosed with cow's milk protein intolerance. At the age of 5 months, he suffered cardiac arrest and was diagnosed with heart failure. His systolic blood pressure was extremely high, and he went on to have 2 further cardiac arrests while remaining as an inpatient in the intensive care. He had a diagnosis of severe middle aortic syndrome and bilateral renal artery stenosis and underwent 4 angioplasties, which were about 5 to 6 months apart. What's really interesting here is that he started to have heart remodeling with a normal cardiac function immediately after the second angioplasty. He was growing, but remained still hypertensive on 4 antihypertensive medications, and therefore we proceeded and did a reimplantation of the left renal artery. He's now about a year after that surgery, takes no medication, and has normal blood pressure with normal renal function. So the message here is that even children who present with, who have severe presentations with heart failures, as this young boy had, can actually develop heart remodeling and should be referred to the nearby center, which has experience in managing complex renovascular patients. So sometimes we can confirm the hypertension, but we can miss the correct diagnosis. So this case is of a 6-month-old boy who presented with viral illness and was diagnosed with systolic blood pressure, which was above the 99 centile. He was one of the 2 non-identical twins, and his twin was perfectly healthy. He was diagnosed with dilated cardiomyopathy, which was attributed secondary to the viral illness, and required 4 medications to control the blood pressure. 5 months later, he had another viral illness, and again, he was seen in the hospital and noted to have a significantly elevated blood pressure. Therefore, the nephrologist was asked for consultation, and his imaging included the urgent CT angiogram, which showed the middle aortic syndrome with right renal artery stenosis and as expected, reduced function in that kidney. His angiography shows severe aortic narrowing and bilateral renal artery stenosis. And he went on to have 2 angioplasties and then proceeded to have an aortic bypass. This is a thoraco-abdominal aortic bypass and bilateral renal autotransplant. His last follow-up from a couple of weeks ago was when he was 14 months after the surgery, and he had a normal blood pressure, was growing, and was not taking any medications. So the first message, recommendations should not be ignored, and blood pressure should be measured as per numerous recommendations that we are seeing from various societies. Holistic approach really needs to take place when we are investigating the hypertension. But as you've seen, even if we do that, sometimes we can miss the renovascular hypertension. So moving on to some initial investigations. What can be the initial investigations that can be performed? Well, echocardiogram and pulse wave Doppler or the duplex ultrasound should readily be available in any secondary care. Echocardiogram will give us a useful information whether we have what we mostly see in these patients, which is moderate to severe left ventricular hypertrophy, but it would be important to be done at the beginning to identify the children who might have starting of the heart failure. Urine dipstick will show us marked proteinuria in most of the cases, secondary to the hypertension. And serum creatinine we obviously check, and usually this is normal, and this is because the kidney develops collaterals to ensure that adequate oxygenation and nutrition to it. However, if we have acute bilateral obstruction or lack of development of collaterals, which we sometimes see, the creatinine can be abnormal, or it can actually swing between the normal and abnormal levels. Serum renin and aldosterone, I'm not sure how much in your centers, but certainly with us, this can take weeks to come back. So not really useful when we are initially managing the patients. We do at this stage advise avoid using the ACE inhibitors while the investigations are taking place, because this medication should be contraindicated in the renal artery stenosis, but can be actually, as you will see, be quite helpful in the intrarenal disease. And at this stage, any discussions with the nearby center which has experience and expertise should take place. Stephanie, if you wouldn't mind the second poll question, please.
So you can vote now.
I'll just read it for everyone. The question is, who manages patients with renovascular hypertension in your center? And just click on one of the options. It's pediatric nephrologist, interventional radiologist, general pediatrician, or other.
We give another 5 seconds. Okay, here's the result.
Yeah, so the results are 89% answered pediatric nephrologist, followed by 4% interventional radiologist, 4% general pediatrician, and 4% other.
Okay, that's interesting. So, doing an ultrasound scan, what are we aiming to find out, or what are we aiming to assess for? Well, it is a good modality because it's readily available in any hospital. It provides a real-time assessment of the flow with peak systolic velocity, information on the acceleration time, and some of resistive indexes. However, it can give some false negative results, meaning that it can miss the narrowing in the distal main renal artery or in the branch stenosis. So you might get a normal report and yet miss the renovascular hypertension. You should also be aware of the normal findings. There was a recent study which looked into the 30 children who had renin-mediated hypertension and reported the normal ultrasound in half of them. And of those children who have had a normal ultrasound but were subsequently diagnosed with renovascular hypertension, a curative endovascular or surgical procedure was possible in about 80% of them. So it's readily available. If you diagnose the renal artery stenosis, it can be helpful, but you can miss still renovascular cause. The second line imaging is the one with the higher sensitivity, and that can be non-invasive or invasive. From the non-invasive, we are talking about the MR or CT angiograms of radionuclide studies. And at this time, if you're opting to further investigate, consideration for referral to the center which has an experience and expertise would be advisable. Digital subtraction angiography remains a gold standard to date for diagnosis, and we'll talk a little bit more about this when we talk about the treatments. So this is a nice picture of one of our patients with an MR angiogram. For this imaging, cannula and gadolinium-based contrast will be needed. We know that these kind of contrasts carry some risk of the nephrogenic systemic fibrosis, particularly in the children who have reduced renal function. It does actually require an experienced radiologist at the time when the imaging is done to oversee the image acquisition. And because the image acquisition is very slow, it necessitates sedation and anesthesia, which adds other complexities. It is susceptible to multiple artifact types. This imaging shows on the right side that the right kidney has two renal arteries. You can see that the upper renal artery proximal part is completely occluded. The lower renal artery on the right side has a stenotic occlusion with post-stenotic dilatation. And on the left side, there is the proximal occlusion of the left renal artery with early branching and narrowing in the middle part of the aorta. So this is a child with a typical middle aortic syndrome. You can see some spinal collaterals there as well. The radionuclide studies, or the DMSA, requires administration of the contrast and then provide static images. Now, it's an excellent modality to provide us with the location of the kidneys, the split function of the kidneys, and maybe help with areas of scarring. We have historically used the DMSA to actually diagnose laterality of the disease. And this image shows that before the ACE inhibitor is given, the function in the left kidney was 46%. Following that, it has reduced down to 18%. So this basically told us directly that the disease is more severe or present in the left kidney only. However, in these days, we use the DMSA for the baseline as a baseline to monitor the improvement following endovascular interventions. So the second message is that low sensitivities of the non-invasive imaging means that we can potentially miss significant and treatable disease. Non-invasive imaging is only part of the jigsaw puzzle. And if you have the normal non-invasive imaging, but yet you have a strong clinical suspicion, then a referral for multidisciplinary team discussion and consideration of digital subtraction angiography should take place. Now, how do you define a strong clinical suspicion? It's never really helpful when we say, well, if you really think this is renovascular condition, refer to us. Agnes Trotman, who's now in Heidelberg, who spent a couple of years with us, has actually published a paper where the strong clinical suspicion for this cohort of patients is defined as poorly controlled hypertension, where you need more than 2 agents, when you have strong clinical suspicion such as brouillon auscultation or evidence of some complications such as heart failure. And never forget associated syndromes, as we discussed before, which might come with renovascular hypertension. You need to keep your mind at all times. We all do. This patient was a 16-year-old girl who was referred to us at the age of 16. She actually had early postnatal diagnosis of total anomalous pulmonary venous drainage and scoliosis. She underwent numerous cardiac catheterizations in her life for her cardiac anomaly and was always noted to be hypertensive. That high blood pressure was commonly attributed to the pain after the catheters were done, but her mother said that her blood pressure at the age of 16 was often 130 even when she was at home and not in pain. She came to our hospital on this occasion for major orthopedic surgery, and Her investigations for hypertension showed a small right kidney with parvus and tardus waveform and reduced uptake in that kidney. She only had one angiography and was found to have OCL renal artery stenosis and was on amlodipine at the age of 17 when her care was transferred to another center. So even us nephrologists don't get it right all the time. So this patient is a 10-year-old girl who had history of 3 urinary infections at the age of 2 years. She presented with history of some nosebleeds, and she was noted to have a heart murmur, then had a blood pressure check which was above the 99th centile. So this was attributed to her bilateral renal scarring on an ultrasound which was done in her hospital, and she was started on angiotensin converting inhibitors. And surprisingly, her creatinine rose to up the 1.5 times the upper normal limit. So this was spotted on. So she underwent a DMSA, which showed a very good split function between the kidneys and surprisingly no scarring in those kidneys. But her 24-hour blood pressure monitor had significant BP load of 83%. She underwent angiography, which showed the right duplex kidney with 2 renal arteries, of which one the upper one was occluded, and also the left renal artery, which was occluded close to the origin. She had aortic bypass and bilateral renal autotransplantation as part of her treatment. And the last follow-up, which for her was about a couple of years now, she had a normal serum creatinine, normal blood pressure, and was not taking any medication apart from aspirin. And all patients who undergo the aortic bypass and bilateral autotransplant continue on a lifelong aspirin. So that's about the investigations and diagnosis and how can some children present. What about the treatment options? Well, treatment can be medical or interventional, endovascular or surgical, but most of our patients, or most of the patients with renovascular hypertension will need a combination of the above. You can also look into the treatment options, whether they are needed as hypertensive emergency or whether we are dealing with a less urgent situation where children are asymptomatic and have incidental finding of significantly elevated blood pressure. And this actually might cause a clinician to have hypertensive urgency himself. So the definition, I'll just spend a couple of minutes on definition of hypertensive emergency before we move on to the digital subtraction angiography. This is defined as a sudden and abrupt severe elevation in the blood pressure from a baseline, and this is the key, from a baseline. The baseline does not necessarily mean normotension, which can cause the life-threatening potential, has a life-threatening potential to cause rapid end organ damage. This is rare, but it can be fatal, and the focus needs to be on the individual assessment and end organ damage rather than how high the blood pressure is. And what I mean by this is that if a 2-year-old child has a systolic of 230 and is playing in clinic, it's probably best not to rush and do anything until the assessment takes place. The aim is to prevent the complications of either hyper or hypotension related end organ damage, such as stroke, blindness, renal, or cardiac. Distinction between emergency and urgency is not really an absolute and is assessment dependent. So which drugs should we choose? We often get called and asked, which drug should we use? Well, the best one is to use whichever one your center has experience in using and whichever drug is available in your center, taking into the consideration rapidity of action, ease of use, and safety of medication. There is absolutely no point of asking for any fancy medication that your hospital doesn't stock, or more importantly, that the nurses are not confident in administering. This table just gives a brief summary of some of the medications, their mode of action with advantages and disadvantages. Continuous intravenous infusion of any of these medications is advised, and the rate of lowering the blood pressure really needs to be fast enough to prevent or reduce the end organ damage, but slow enough not to cause the hypoperfusion. We need to think about the long-term autoregulation and the blood pressure that the brain has used to functioning. The complications are significantly lower if the infusion is used versus the boluses, and this has now been published in a paper from nearly 30 years ago. The first phase is the principle of quarters. We usually say, let's aim to reduce the blood pressure to the normal baseline by 25% every 6 hours and aim for it to be below the 95th centile over the next day or two. There is no quick fix, and rushing to do something can cause more harm than benefit. There is an open debate whether we can be more aggressive in treating acute hypertension rather when we are dealing with uncontrolled chronic hypertension. And having 2 cannulas when you can run a bolus of normal saline if you drop the blood pressure is essential. For those who remit oral antihypertensive drugs and do not have the need for intravenous treatment, a wide variety of medications is available again. We advise again against the use of ACE inhibitors if we have a renal artery stenosis. However, this is a drug of choice when there is no stenosis in the main renal artery and when we are dealing with intrarenal disease. So the last poll, question 3, before we summarize.
Yep, and I'll just read it out for everyone. The question is, does your center perform digital subtraction angiography? There's only 2 options, yes or no. Okay, and it's pretty evenly split. 54% of respondents said no, and 46% said yes.
Excellent. We'll have fantastic discussions at the end of this talk then. Fantastic. So digital subtraction angiography, beautiful images. As you can see on this picture, middle aortic syndrome with bilateral renal artery stenosis. It is an invasive imaging, but as well as imaging, it also offers the treatment opportunity. There is an ongoing debate between nephrologists, interventional radiologists, vascular surgeons, anybody who's involved in the care of these children, whether we should stent or not stent. And that dilemma really is an ongoing. In our center, the preference is to avoid using the stents, and the reasoning for that is to preserve the vessels for future surgery if it is needed. However, the centers who prefer to use the stents have also reported good outcomes, as we will see later on. It might require multiple procedures for treatment, and it's usually a combination of the medications and endovascular procedures that most patients will need. Can be curative for some, so one intervention can actually cure if you have unilateral disease with ostial unifocal stenosis. However, it does not help with intrarenal disease, and this is where you can freely use ACE inhibitors. This is an intervention which should be performed in a high volume centers with experience and expertise. Despite that, sometimes we need to opt and do a major surgery. So which patients should undergo vascular surgery? Well, if we have no sustained improvement with repeated endovascular procedures, and this is what any paper that you can read out in the literature will actually quote, but after how many angioplasties, the jury is really out. This surgery should be considered for patients who have significant aortic pressure gradient and in ideally older children, or if they have a non-hypertension related symptoms such as the claudications, as we've seen in some of our patients. It will not treat the intrarenal disease, and the surgical approaches really are variable and lesion dependent. But all the surgical outcomes that are reported in the literature definitely agree on the importance of the operator experience that can't be overstated. So it's not a surgery that should be lightly undertaken. With us at GOSH, our Reno-vascular service started by 4 individuals nearly quarter of a century ago, has now grown. We get a lot of patients referred from abroad, meet twice a month to discuss new referrals, and we to date have grown from 4 individuals to having 9 pediatric specialties who regularly attend with 23 members. But all of this is done with strong collaboration with colleagues in local hospitals who remain the lead clinicians for these patients. A little bit of innovation. So what we have done, we have copied what the transplant service has done in our center and used the images from a CT angiogram to 3D print the model before we operated on our first patient a couple of years ago. And this model not only aids the planning of the surgery better, therefore enhances the safety of the procedure, but it is also found to be very helpful when getting the informed consent from the parents and from the patients themselves. So nice colorful 3D models which give details about the vasculature or the organs, which can be printed as well, so surgeons can plan how to operate. So what are the outcomes of children with renovascular hypertension? Well, these are the healthcare definitions of the outcomes, value-based healthcare, but I think for renovascular one is definitely something which is condition-specific and multidimensional. These are the papers. I will not go into detail of all of them, but Houston, Boston, Toronto, and us in London have a huge experience, and in the last 10 years all have reported large number of patients and experiences in performing the angioplasties and vascular surgeries or management of the patients with renovascular hypertension. We've reported on 78 children in 2015, and this is what Charles, Steve, and Professor Schoch have reported on, followed by the colleagues from Toronto and Houston. All of these papers have agreed that the favoring is for using the percutaneous techniques, and the goal of that is to prevent the end organ damage and to allow of the growth of an agent size more amenable to definitive corrective surgery. The percutaneous transluminal angioplasty is a worthwhile intervention and could be sufficient for most of the patients if it is done in center with expertise, experience, and equipment. So all 4 centers agreed on that. It does give low complication rate with some favorable side effect profile. It can be curative in 36%, and it can improve blood pressure in the further 30%. So about 2/3 of the patients will have significant improvement. We've looked into the surgical outcomes for our GOS patients. We have had 23 patients who underwent surgery. That's 12% of our cohort. You can see from this that we favor repeated endovascular procedures over surgical for as long as possible because they're minimally invasive with very good preservation of the kidney function. The renal autotransplant in our cohort is associated with significant decrease in the number of antihypertensive medications, which then helps with adherence and improvement in the blood pressure. So how do we follow up these patients? Well, the patients should be followed up locally whenever possible. The expert care should be delivered closest to home. And now with video consultations and collaborations with local colleagues from local hospitals, this has even been made easier. If the blood pressure is rising and you need to increase the medication or need to add more medications, or if there is a rise in the creatinine, this would need a re-evaluation. Initially the DMSA and a Doppler ultrasound scan, and then discussions and maybe re-referral for the re-intervention. However, it's the individualized approach, as all of these children, most of these children actually come with very complex conditions. Now, what about the patients? We look into the clinical outcomes, the blood pressure control, the number of the medications, how do our patients feel? So the quality of life and the patient views, as it stands, there is no targeted published data on quality of life in this patient group at all. So we took the opportunity to survey our patients. And when we looked into the patients who have undergone the surgery, the lower score means poorer quality of life in these questionnaires. So the lowest scoring was in our patients on treatment anxiety and on the communication, and the highest scoring or a better quality of life was actually on the medicines and pain and hurt. So the patients had less symptoms and were taking less medications. Interestingly, parental concerns were always about the lack of the understanding of their children in the community. So how this can be taken forward for anybody who looks, if this is to be replicated in other centers, is that the focus really needs to be on the hospital experience pre and peri-operatively. Maybe the role of the play specialist for younger children and youth workers in planning of the surgery should be considered. However, we are having some more data that we'll hope to share soon. So, in summary, the renovascular hypertension is a rare but important cause of hypertension in childhood. Awareness of the variable presentations should prompt targeted investigations. Now, the high sensitivity imaging is essential for diagnosis, but clinical suspicions should always outweigh any imaging. And it's a combination of the medical, interventional, and surgical treatments that can be offered to these patients. Clinical outcomes are excellent if delivered in centers with expertise. And it goes without a doubt to say that it takes a village to raise a child, but it definitely takes a multidisciplinary approach to manage these patients. Thank you.
So great. Thank you so much, Jelena. And as questions come through, so I remind everyone, if you have questions, to write them on the question box in the GoToWebinar window to the right-hand side of your screen. We do have one question that has come through, and this question is regarding hypertension in children with atypical hemolytic uremic syndrome. So the question is this a Reno-vascular form of hypertension, and how is it best managed?
In children with atypical hemolytic uremic syndrome, I don't know if you want to talk about this, Marina. But I think it would not be considered as a cause of renovascular hypertension. I think the pathophysiology of the atypical HUS would more go towards the glomerular diseases as a cause for the hypertension.
Okay, that's really interesting. And I'm going to ask you a question as things come through. So why do you think that such a high percentage of children have an ultrasound that is negative with the Doppler being normal? I found that quite surprising. Do you think it's dependent just on the experience of who performs the ultrasound? Or what are the forms in which the ultrasound is going to be normal? I think that might be fascinating for people to know more about.
Yeah, so I think it definitely is a combination of the factors. So having the radiologist experience in actually imaging the children who have over and over, who have the renovascular hypertension or renal artery stenosis in the main renal artery, certainly goes without a doubt as a reason. So the more you do something, the better you become. That goes for anything. However, a lot of these children will have intrarenal disease, which will not be picked up on a Doppler ultrasound scan. As you've seen on some of the imaging that I've shown, they will have multiple renal arteries which would be occluded and therefore might not be actually visible to see any flow. So you can't see the parvus-etalvus waveform, or the occlusion might be in the distal parts of it. So it's very rarely that we would see somebody who would have an ostial stenosis, which will then be very easily to be diagnosed. And sometimes the tarvus and parvus waveform is not that distinguishable if you have the narrowing alongside the whole length of the renal artery. If you have ostial stenosis or the isolated stenosis, then you will see this much more easier.
Okay, great. And you have now another question from Dr. Carolina Peralta Aros, and she would like to know, which do you consider of the different imaging techniques the gold standard for diagnosis of renovascular hypertension? And she thanks you for the session as well.
For the diagnosis, well, if you want to be absolutely sure, it would be digital subtraction angiography, which, as we've said, is also a treatment possibility, which is done at the same time. However, if we really think about what's feasible in most of the center, I would probably say CT angiogram would actually go in front or ahead of the MRI, but those of the radiation and effects of it also needs to be outweighed. So I would go with a digital subtraction angiography if it's possible, being an invasive, but from the non-invasive, I think a CT angiogram would be the best.
Great, thank you so much. And while other questions arrive, I also wanted to ask you about how to measure blood pressure in children. I know that this is a very debated topic, and I know that you at Great Ormond Street Hospital have particularly high standards in this. And I think it can be useful for everyone to get your insight on how best to measure blood pressure in children.
How best to measure the blood pressure in children. So let's hope that I've learned something from Eileen Brennan, our hypertension consultant nurse over the years. Well, in the children who are less than 5 years of age, we would advise use of the Doppler methods for measuring. So it's always the manual. We would advise avoiding really oscillometric ones. So if you are measuring the blood pressure, the manual methods, Dopplers for children younger than 5, and then the older children can use the manual blood pressure, can tolerate the manual blood pressure, because basically they can sit still and the arteries are bigger, so you can detect. However, that is if you want to be really nitty-gritty about it. The children with renovascular hypertension will have very high blood pressures, and this will be documented. This will be picked up on the oscillometric. And if you and that is something that we know even at Great Ormond Street Hospital. A lot of our wards will not have the Dopplers. Non-renal wards will not have the Doppler methods and will have the oscillometric ones. An oscillometric measurement of systolic of 140 in a 2-year-old child is abnormal and should trigger the referral.
Okay, great.
Stuff, I just think probably is the more important thing than which method, using the adequate cuff size.
Yeah, of course. Yeah, so the cuff is crucial. So in your experience, these kids at home, do you have them use an oscillometric machine? What do you recommend?
Yes, so I think our hypertension service for the children that need to monitor the blood pressure at home, yes, the Doppler measurement for the younger children, definitely. Sometimes we do use the oscillometric, as long as it's always the same method, so that we can see the difference in the blood pressure readings. It's not always possible. In our center, we at least do not provide the Doppler machines to the parents, so sometimes this needs to be self-funded as well. So not always easy to provide the best.
Yeah, of course. And I also have another question. I realize that these are forms in which normally, as you were saying, you know, it's not a subtle hypertension, it's a severe hypertension. But I was wondering, what is the role of a low sodium diet in your experience? How much in percentage can that help you to control the blood pressure?
In renovascular hypertension, it doesn't really help, because that's we know that the pathophysiology is different and the etiology is different, so it really doesn't help, because these are the children who have significantly higher blood pressure. Now, of course, healthy diet and with low salt might help, but these children usually need interventions, and the vascular or surgical for the management. So we don't, I hope nobody from GOS hypertension team hears me, but we don't really in renovascular service go that much into the diet, because we know that the difference that the low salt diet might provide in the cohort that we have is minuscule, really.
Okay, no, thanks. That's really interesting, because obviously in the glomerular forms instead, it's so much more important. And I just wanted to highlight that difference, because I think that sometimes we are even excessively, at least in some centers, insisting on that aspect, whereas in these anatomical forms, it really doesn't make that much difference.
Exactly.
We already have a lot of burden of disease, so it's useful, I think, to try to simplify things and make, you know, make their lives as simple as possible. I think we're done. This is really, really interesting, and I don't think that there are any other questions. So, and I also think that you are available, and people can send you emails with questions if people think about it later. Okay. So I'll just give it 2 more minutes, but I don't think there's anything else coming through. So at this point, I would wrap it up. I'm not sure, maybe Stephanie can help us. Do we have an announcement for the next webinar before thanking Jelena?
Jelena, you have still the slide?
Yes,
available?
if you allow me to share it, I can show the last slide.
Wait.
Just to allow me to share the screen, and I will do it.
One second.
And as we were waiting, another question came through, Jelena. Philip Warnell was asking, when you're measuring blood pressure and you're using oscillometric measurement, especially in younger children, do you target the mean arterial pressure or rather separately systolic blood pressure and diastolic when treating?
Our focus is on systolic, I have to say. We focus on systolic. It doesn't mean that it is right, but our focus is on the systolic blood pressure.
Okay, so you're focused on systolic. Great, thank you.
Can you see the screen? I hope that.
Yeah, so the next one, the next webinars are June 14th, when to perform genetic testing in Kakut and what to test. Nina Kners from Groningen will be giving a talk. And then we have June 28th with Gisselman Syndrome Adult View by Tom Niehoenhuis from Nijmegen. And then we have a break for the holidays, and then we go to September 13th with Diabetes Insipidus, which will be given by Danielle Bichet from Montreal, Canada. Okay, well, with this, yeah, you're getting lots of thank yous and congratulations, but I think no more questions. So thank you so much, Jelena. That was a really, really excellent talk, and I think we all learned very much. It was a real pleasure. And see you in June. Thank you very much.
Thank you. Bye.
Thank you. Bye-bye.